and Control of Rabies in India, APCRI. Sir, welcome to the show. Thank you for joining. We welcome Mr. Nitin Jain, Senior General Manager, Zydus Vaccines and Equals 2. Sir, welcome to the show. Thank you so much for joining. We also welcome Mr. Shakul Srivastava, who's Vice President of Human Biologicals Institute, Division of Indian Immunologicals Limited. Thank you so much for joining, sir. With that, let us start with the discussion. So for our audience who is watching, this is the 4th edition of Rabies Awareness Summit. As today is World Rabies Day, the initiative is aimed to generate awareness around this rabies issue that India is working very actively towards. But the statistics around rabies are also very alarming. It is seen that according to the information of World Health Organization, one death occurs due to rabies every 15 minutes. 80,000 to 20,000 deaths every year are predicted due to rabies, but the true burden is still unknown due to the variation between point prevalence and period prevalence. About 30 to 60% of reported rabies cases and deaths in India occur in children under the age of 15 years. And most of the deaths, that is 98 to 99% of human deaths, are caused due to infected dog bites, followed by other animals such as mongoose, cats, and cattle being at only 1%. Vaccinating in 70% of dogs breaks rabies transmission cycle in an area of risk. So on these lines and also other news that has been emerging in the last year around rabies, we would be discussing this topic more in detail. So my first question is to Dr. Ashwath Narayan. Sir, we would like to know that are there any persistent gaps that are faced around categorization of the bite? And why is categorization of bite still seen amongst doctors and healthcare workers as such a big challenge? Can you please enlighten us? Sir, can you please unmute yourself?
Thank you, madam. So categorization of animal bite exposures among the people who get bitten, those who come to the anti-rabies clinics or any hospitals, is a very important and essential step which determines the treatment mode, what we are going to advise. So you know that in categorization we have 3 categories, category 1, 2 and 3. So category 3 usually doesn't require any treatment, and if anybody comes with category saying that they have touched the animals and they have some anxiousness, so usually we advise, especially for pet owners, their pre-exposure vaccination. But for giving the very important life-saving immunoglobulin, we need to categorize it as category 3. But it so happens in our hospitals, when they come in, mainly in the government hospitals, I will divide it into government, what is the problems in the government, or what is the problems in the private hospitals. Hello?
Yes, please go on. Yes.
Yeah. So in the government hospitals, usually these cases are usually seen.
I believe there is some background noise coming. Please request all the other panelists who are not speaking to mute themselves so that we can hear Dr. Ashwath very clearly. Yes.
Yeah.
So
am I clear? Am I clear?
Yes,
am I audible?
Yes,
okay. Okay. So I will just going to just elaborate what are the problems faced in the government and private hospitals separate. Whenever the animal bite cases comes to the government hospitals, usually these are seen because the doctors will be very busy. So usually this will be seen by staff nurses and pharmacists, right? Very rarely by the other doctors. Okay, and in the private, in the medical college hospitals, we have the continuous rotation of these junior doctors who need to be told or oriented regularly. Training has to be given regularly. Okay, see, these are the problems the government. When it comes to private hospitals, usually when they go to general practitioners or in nursing homes, usually they are seen by doctors, whoever is on the duty, or maybe general duty doctors, or in the casualty. These are cases. And here, these doctors, they have a lack of knowledge as far as the categorization of wounds, because they are not only seeing only animal bite cases, various other conditions also, which are coming to the kind of patients who are coming to the casualty or the OPDs. So usually they don't have a thorough knowledge about categorization of wounds. And this categorization, especially category 2 and 3, lead on to confusion among the many doctors, not only the healthcare workers in the PHCs, even among the doctors, it leads on to confusion, category 2 and 3. So just to elaborate on that, we usually do a spirit test to differentiate between category 1 and 2 in the OPDs. If it burns and there is no bleeding of wounds, bleeding from the wounds, it is category 2. Okay, and there are wounds, even a small drop of blood which has come from the wound, it is category 3. Okay, so there is no blood, neither burning of sensation, burning sensation in the skin. That means it's category 1. Very, very clear. No bleeding, no burning, it is category 1. After applying spirit, it is category 2. Even if you have a single drop of blood, it is category 3. So it's very, very simple categorization, very easy. But doctors are getting confused. So they would have been told by different sources the categorization. They will have their own understanding. A severe bite is category 4, 5, 6, like that. They would have read from different sources. So they don't follow the standard guidelines given by the government. So these are all the various reasons why you have categorization problem. And second important reason by many hospitals, both what we have seen in both government and private hospitals, is reluctance to give immunoglobulin, the life-saving immunoglobulin or the monoclonal antibodies. If they categorize as 3, then they are how to give compulsory immunoglobulin or the monoclonal antibodies, which they don't want to give. There is apathy or negligence on their part. So they just do category as 2, and they just give vaccine and they will send the patient away. So these are the important reasons why we still have problems categorization and treatment part, and it's leading on to death of this animal by patients and having rabies subsequently.
Thank you so much, Dr. Ashwat. We will come back to the aspect of strengthening the existing workforce with knowledge and capacity building later on. But before that, my question is to Dr. Omesh Bharti. Sir, it is observed that cases of dog bites are high in number in the hilly regions and areas like that, which has been observed. So please, can you share some state level or municipal level efforts that are being carried out, not just to create awareness around rabies, but also some prevention efforts that you are being part of?
So thank you, ma'am, for organizing this seminar. Can you hear me?
Yes, sir. Please go on.
So let me clarify that the cases of dog bite has gone exponentially high, not only in hills, but in plains also. For example, in Himachal, in 2008, 7-8, there were 10,000 prophylaxis. Now it is 60,000 prophylaxis. So everywhere they have multiplied 5 to 6 times than the previous figure. And that is because of the municipalities not killing the dogs, and ABC program failure by the municipalities, and nobody is looking after the dog population management in the villages. So these are the contributing factors for exponential growth of these dogs and dog bites, both. So I think a lot of action need to be there to prevent their population growth, and vaccination of each and every dog, at least 70% vaccination of the dogs. So this is one reason. Regarding prevention efforts, now Government of India has sanctioned money for doctors' trainings, for IC material, for radio jingles, We have money now available in the NHM funds for rabies control under National Rabies Control Program also. So I think now we are in better position because we have minimum resources. Otherwise, earlier we didn't have any money to popularize the preventive measures in dog management and rabies control. So I think situation is slowly improving, and we are moving towards better position for the awareness and even for vaccination. We have resources for vaccination and immunoglobulins. We have resources for training of doctors and paramedics. So I think we are now in a better position to spread this rabies prevention activities. Thank you.
Thank you so much, sir. We will come back to you again regarding other efforts around awareness generation around rabies and its prevention. My next question is to Dr. M.K. Sudarshan, sir. Sir, being the founder of APCRI, can you please talk about how important dog vaccination is in supporting nation's efforts towards zero deaths from rabies by 2030? So, and how can this be achieved? Because there are some states who are actively working towards dog vaccination to eliminate rabies, as studies state that 70% getting vaccination to 70% of dogs would cut down the cycle. But at the same time, due to COVID, there has been observed that the activeness of these efforts got down after COVID. So can you please throw light on this aspect?
Yeah.
So you're not.
Thank you.
Yes.
Thank you. Let me come to the points one by one. Now, first about COVID. COVID is gone in all practical sense in 2022, and now some residual infection circulates, and there is no threat per se. All COVID protocols are removed. So we are back into pre-COVID action right from middle or end of 2022 for almost a year. Now, having said that, now the important aspect is in India, 97% of human rabies deaths is due to dog or dog bites. Globally, it is 99% by dog bites. So that's why 0 by 30, that is, nobody should die of rabies following a dog bite by the end of 2030. So if we can remove rabies in the dogs, which acts as a source, then I think we will be in a position to eliminate dog-mediated rabies. So this is something which we need to keep in mind. So that's why all efforts are now directed to minimizing and eliminating rabies in the dogs. So vaccination is an important component, dog vaccination. And dog vaccination, there are certain requirements, like 70% of the dogs have to be vaccinated. And this has to be done in a specified period of about a few months, 6 months. And that has to be continuously carried on for a period of at least 5 to 7 years. So I think this is a challenge, and this needs to be achieved. Now that Government of India has initiated NAPRE, National Action Plan for Rabies Elimination in the country in 2021, and it is now quickly rolled out, and various activities are taking place. I think we will make some good progress, and we will see in the days to come that things are moving quickly. Thank you very much.
Thank you so much, Dr. Sudarshan. Moving on to Dr. Poddar next. Sir, can you please highlight, in your experience, in your observation, what the challenges that exist in the availability and uptake of rabies vaccines and immunoglobulins? And does our country have sufficient supply of the same to minimize the estimated 18,000 to 20,000 deaths that estimatedly occur every year due to rabies? What are your thoughts on the same? So can you please unmute yourself?
Hello,
Yes.
am I audible?
Yes, yes sir, audible.
Am I
Please share.
audible? Okay. It's a very good question. That is, a lot of challenges are there. We had a dream that a rabies-free country will get the rabies-free country by the year of 2030. So it is our dream. Naturally, it is our main thing to work on that aspect so that we can control rabies in India totally, at least involving also the SARC countries. So SARC countries has to be also involved so that the surrounding countries will be free, then India, of course, will be free. Rather, India will be free and the surrounding country, of course, will be free. So there are many needs. As you were doing this kind of programs, VIRAM and all these things, this kind of programs with the help of APCRI and also with the government of India. And so we'll have to try for the next, what we are meeting, the challenges, what we are meeting. That is one thing is still we are lacking that ABC program has not yet been fully incorporated. That is the main thing. That school level, the children are the common victims. The school level education is still not there, and the pre-exposure prophylaxis is not being achieved. So, to control rabies in our country, the implementation of pre-exposure prophylaxis is very important. And I think Dr. Ravish is also working on this particular aspect for pre-exposure implementation of pre-exposure prophylaxis. So this is our final date, that this year the theme is also different. That is all for one and one health for all. This is our theme. So we'll have to proceed accordingly. We'll have to give vaccines to everybody. All the patients should get the pre-exposure prophylaxis so that the need for the our implementation of REG will be reduced, amount of REG will be reduced, and also the cost ultimately will be benefited. So it is our real challenge that we do not have the common sense regarding the wound toilet. So it is at least 50% responsible. We can do the proper wound toilet, the chance of developing rabies will be reduced by 50%. So we will have to think on this aspect also. So implementation of these programs, placing the hoardings in different states, different corners of the streets, it will be very beneficial. School level education, involvement of other NGOs, that is, along with APCRI, the Rotary International, the Lions International, they can join like that. They can join with us, and also the government is the prime main source. They will be motivating force. So they will have to, definitely they are doing it, definitely, otherwise the death rate should not be less than whatever we are achieving today. That is, death rate has to be reduced by implementing all these things. So these are the challenges. No conception about the wound toilet, no vaccination to all. That is another one. In the district levels, they are not getting the vaccines. Do not have the proper ideas. These are many myths are there. So it has to be removed. So this is with the help of APCRI, the WHO, and the NCDC. We are doing all these programs. And definitely our driving force is definitely Dr. Sudarshan is there, Ravish is there, and Ashwadnaran is there, Umesh Bhatri is also there. They are also everybody, we are just working as a team. So this is very important, that to involve the NCDC and to maintain the guideline stipulated from the NCDC, that has to be it. And another important thing, madam, that is the reduction of the dose of the vaccine. That is very important, because we are already started with the 14 doses of nerve tissue vaccine. Then it came down to 5 to 6 doses of the tissue culture vaccines. Now it is 4 doses of giving the tissue culture vaccines. We'll have to try to discover, to highlight, particularly for the minimum dose of vaccine, that is 1, 2, 3, 3 or 4 doses will be sufficient for protecting the patient against rabies. So these are the challenges that we'll have to go, that we'll have to achieve. So we'll have to go for with a very hard work, with your kind help, and also with the help of the NCDC, and our APCRI is jointly doing these programs, and also Delhi is there from the NCDC, and so these are the main things. So I will request everybody to on this day, this is the theme is all for one, or one health for all. Next is important thing is we have seen some of the patient are not properly being treated in the, although he will die, but there is no such unit so that he can be treated at least in the last day of his lifetime, that he will get the proper treatment. It is there also some records are there that the patient also survived after a long journey, long treatment after that one. But it is to be kept in the mind that rabies is 100% fatal disease. Once it is developed, that the patient will not be saved. Anyway, research and other innovative ideas should come forward, and we'll have to work together. We'll have to. We have a dream, and this is the time has come that to make the dream into reality. So it is very important that we'll do it, all the programs in the school level, in the local village levels, also in the several districts, also in the community level. So these are the main thing. Awareness is the main thing. And unfortunately, I'm telling you, there is no still awareness about the concept for the wound wash. That we'll have to think that under running water, tap water with soap and water, it should be washed for at least 15 minutes. This basic hoarding should be placed accordingly. And APCRI will definitely work for this.
Thank you so much, Dr. Podar. And we will come back to all the points that you have shared and discuss them with our other panelists here today. My next question is to Mr. Shakur Srivastav. Sir, as Dr. Sumit Podar was highlighting that pre-exposure prophylaxis is very important. So can you please discuss the importance of pre-exposure prophylaxis among especially the vulnerable population, which includes children below the age of 15 years, or amongst people who reside in high-risk areas of dog bites? How important is this, and should this be a part of the vaccination card that children are given, as most 70% of the dog bite cases are amongst younger populations? What are your thoughts?
Yeah, thank you, Dr. Sawant, and thank you, IHW, for having me here. Am I audible?
Yes, sir. Please go on.
Perfect. So thank you so much for having me here. See, let me give you a bit of preamble before I come to the points raised by other panelists. We have been dreaming about it to make India rabies free. But why it has been elusive so far, if you look at? Till a couple of years back, the images, if you see it around any talk of rabies prevention, we always showed, very horrifying dog and a lot of blood oozing out of the wound after the dog bite. Okay. And it was like the perception of that is that as if the dogs are our enemies. So we need to understand this. It's a very symbiotic relationship. We both need to coexist. In this regard, in 2019, having many of these panelists in their presence, 4th January, 4.5 years back, we launched a campaign called fearlessagainstrabies.com. So that's a website. And there, that is where we picked a very cute child, a very beautiful spaniel dog, and we put them together. So it's just like a good friend next door. Okay. Recently, when I visited one of the conferences, I saw several companies have just simply copied that. I was so happy to see that, because if being a pioneer, we could inspire somebody, because that is what we need to promote. They're not enemies, like they're not horrifying. They live with us and we live with them, right? So now, why it has been elusive and why pre-exposure prophylaxis has not been achieved? If you look at closely, what we do one of these kind of programs. I'm not finding faults, but trying to tell you facts. Once in a year, and largely these events, these programs happen in English language. What population of our country understands English and speaks English? And who's bitten by dog? Is it the people who speak English? Answer to that is a big no. It happens to villages, it happens to school-going children, and the methods that we adopt for pre-exposure prophylaxis or awareness about the dog vaccination, we try to put into their syllabus or children education. That's a very, very long rope. Now, with the use of availability of internet and several social media, things have changed, right? So probably time has come for us, as we intend to eliminate dog bite by 2030, or possibly if prior to that. There are shorter ways now to reach this generation and these people. Those ways could be, you see, there are several influencers, digital influencers on Instagram and all that. They have millions of followers. They show, keep on putting so many videos, TikTok videos, this and that. Basically, it's a comedy thing. If they can be hooked to do this, serve this purpose, this new generation follows them. Okay, our message would reach a very large population overnight. Second, several regional event programs we are doing. Like yesterday also we did one in Hindi. So state-wise, because we have to reach farmers, we have to reach to villages. And third and largest thing, about pre-exposure or post-exposure, what has been the hindrance is the awareness. So people people are not aware of how to manage, or at what level they should visit a doctor. And it really worries me, despite so much of effort, despite so many meetings, despite so many good talks, when we read in newspaper or hear in news every single day, practically, that a child was bitten by dog and he did not tell parents because out of fear that parents will shout at him. And he told that I caught up some quarrel with some of the classmates in the school, and that's how these scratches are. And just few days later, child develops rabies, and then we cannot bring him back, and the child dies. So first level is, parents have to be aware, children have to be aware, and that the channel between parent and child has to open, because children are the main victim. Also, suppose child says, I was bitten by a dog, or let's say a dog played with me and I got few scratches. This parent should be aware that this is the time to visit a doctor at least. And all through, in all our communications, and several companies are joining hands day by day, we promote only one thing. We don't say use this brand or that brand, or use my product or his product or her product. All that we say, please know the disease better. It can be 100% prevented, provided you approach your physician. So these are the certain ways, madam. And we have, we are doing several campaigns. This whole week we are celebrating. We don't just celebrate on this one particular day, but it's a 365 days work to involve pediatricians and children visiting pediatricians on Saturday. We are trying to go there. We are trying to even provide few free doses if required to some children who can't afford, as a pre-exposure prophylaxis. Because dog vaccination, castration, population control, all can happen, but that's all going to take time. What I can do today, I can protect myself by taking just few doses of rabies pre-vaccination. So these are the few things. If we do today, I think by involving influencers, today's influencers, digital way of doing things, by involving a larger population, educating farmers in their regional languages so that they understand better and act better. Availability is not a concern. Channels are not a concern. Probably we can achieve by 2030, or maybe in all likelihood before that also.
Thank you so much, Mr. Srivastava. So you highlighted a few different areas that are barriers for us to reach goals towards zero rabies deaths by 2030, and that has been well noted down. I will come to the awareness aspect around the younger population with Dr. Umesh in a bit. But the other areas that you mentioned, that language barrier being the biggest one, Awareness is required, and the means to generate awareness in local languages more, because those are the people who get bitten by stray dogs the most, as observed. So yes, a big need is there, as you shared, to incorporate digital influencers to enhance our reach for the new age population. We have been observed that while IHW Council is working with influencers that matter, one of the main barrier that we observe from their side is they portray that whenever we are doing a food related video, or whenever we are putting out content related to fashion, it is very well accepted from the audience. But if we talk about anything related to health, people are simply, half of the population is not interested. So maybe making our content more engaging, more innovative, in the sense that it is well received by the new age population as thing to follow, is also need to be looked into. That not just using those portals, but also the quality of the content that we are putting on is easy to grasp and easy to from the audience. And also, yes, reaching to more villages where network and internet connectivity is not so much, in the areas where they are not reached by the government or the local bodies as much because of many different barriers, connectivity or language, etc., also need to be looked at. Let us talk about the VIRAM initiative that is in partnership with IHW Council, the initiative that we are supporting today from Mr. Nitin Jain. So can you please share a little about the Full Stop on Rabies initiative, VIRAM, and the kind of impact that is helping to create around rabies awareness?
Sure. Thank you, Dr. Sawant. And a lot has been spoken about my co-panelists. They have brought forward the challenges and the barriers currently we have in India when it comes to the rabies management. But before I delve into VIRAM, it is essential for me to highlight certain challenges which have already been spoken about. But in terms of the statistics, we see that 60 to 80% of the animal bites today are actually category 3, but they are not rightly categorized. And out of that, probably 20 to 25% of them are getting passive immunization. Understanding the gaps at multiple levels, we reached out to more than 5,000 healthcare professionals, which included pediatricians, emergency department heads, government department heads, ARV center staffs, patients who had suffered from the animal bites, and that led to the foundation of the VIRAM initiative. VIRAM is a full stop on rabies, is an initiative which is comprehensive in nature, which is cutting across the multiple stakeholders who are into the animal bite management. Our primary objectives are basically fold. The first, we want to enhance the bite categorization awareness. Every one of my co-panelists have spoken about it. And today, the major challenge remains is whether the bite is category 1, 2, or 3. With this initiative, we want to improve the awareness and provide education to healthcare practitioners for the correct bite categorization. This would ensure the right level of treatment. The second agenda for us is the standardizing the treatment protocol. While there has been the active immunization which is happening, the passive immunization continues to be a challenge. And with this initiative, we want to collaborate with the government bodies, all the societies like APCRI, Consortium of Rabies, local societies, to ensure that there is a treatment protocol in place which would help for the effective management. The third one is the larger community awareness. Now, there are, it would require the 360-degree management utilizing the digital platforms. Shakul has already spoken about the influencer, vernacular languages, but creating a compelling story which is engaging in nature, and that's what we want to do. Under this initiative, we've been working with government societies, with the private societies across the broad spectrum, encompassing both private and government setup. We collaborate with organizations like APCRI, IAP, Consortium of Rabies, and other societies. And over the past 2 years after COVID, we have created a skill development program for healthcare practitioners, through which we have already done 1,500 programs, already reaching out to more than 10,000 to 15,000 healthcare practitioners for developing the skill and knowledge about managing the animal bite with the right categorization and with the standardized treatment protocol. Our goal is to create a substantial impact on rabies awareness and prevention. Through this VIRAM, we want to save more lives, definitely by ensuring that the right knowledge is available across the spectrum, because we know that it is starting from the community, reaching out to the healthcare practitioner, and everywhere there is a gap. So we want to collaborate with the larger community, make sure that India is safer and more informed in the fight against rabies.
So much, Mr. Jain. So we are at 12:10 right now. So just managing the time for everybody. I will take one questions from all again. Just requesting everybody to keep it precise. My biggest question now to Dr. Umesh is, sir, as we have been hearing that awareness amongst the younger children is most important. So are there any activities that the government is involved in regarding raising awareness around rabies and dog bites in schools, particularly as children are in schools most of the time? So any yearly awareness programs that we can do to the school children, and that can be applied to all across the nation, so that they are also made aware what to do, the 1, 2, 3 steps after getting bitten, or how to at least inform their parents and not hide it and avoid aggravating the disease. So can you please unmute? Yes.
This is a very good question. Actually, first step is to make general public aware. So I think before we go to, it's better we go to the schools. But I tell you, even today my talk was on All India Radio. So we have to find the gaps in the community. Like here, people still put some chilies or some turmeric on the wound, and then they think it would be treated. So then we should know the local practices, and we should try to dispel all these myths that putting some chilies or putting some holy butter or some turmeric would treat the wound. So that aspect I highlighted in my talk. So I think first important thing is we go to the community and highlight the myths, because the myths go from elders to the children. So whatever we teach them in the school, they may not listen to that, because their parents are saying, their grandparents are saying, do like this and everything would be okay. So I think we need to go to the community. Definitely we need to go to the schools. Maybe the teachers are also part of the community. So maybe we have to first go to the community, go to the teachers, and then think of going to the schools, because that involves funds. So that involves more activity from the NGOs. And this Fearless Against Rabies, I really congratulate them that their website is very up to date and very fantastic as far as awareness. I think other like VIRAM initiative is also very good. And we need to make these initiatives more interactive for common people, more interactive, because I know even Dr. Sudarshan would agree and other experts would agree. People keep on calling so many times. They are so fearful of rabies. They keep on calling and calling and calling. So I think we need to have more and more website platforms where they can get knowledge, they can get their myths, their misconceptions clear. Only then we can spread this awareness in the community, in the children, in the school teachers. I think that is very important. The government being this National Health Mission, we have some funds. We are planning to go to the go for jingles to the radio, and today all newspapers are full of anti-rabies, World Rabies Day advertisements, what to do, wound washing, injections, everything is freely available. That is also highlighted, because still people think that we have to pay. So that is also very important to highlight, that it's free now. You can access any nearby center and you would get free vaccine and free immunoglobulins. Thank you.
Thank you so much, Dr. Bharti. My next question is to Dr. Ashwath, sir. As it has been highlighted that there is a wide need to strengthen the existing health workers' capacities to adopt to giving not just vaccine but also immunoglobulins wherever necessary, identifying the need, proper categorization of the bite is a give in, and also as suggested that we are not just reaching those to those healthcare workers who are part of the government or are very successful in their private practice, but those medium level practitioners as well, who are not being touched by the either government or the organizations that are working, such as product organizations in this regard. So how can we reach to those healthcare workers as well as our existing healthcare workforce to strengthen them with the latest information on the products that are available, the techniques that are new, and also inculcating this aspect of making the patients that come to you also aware about this regard, so that in future the similar families do not face the same consequences.
Yeah. So, as you said, it's very important to train not only the government people who are working in the government hospitals, but also in the private, and even at the remotest place also, peripheral level, where they will be missing this post-exposure prophylaxis if they are bitten, and because of the lot of myths which are there among the people. So we need to clear those myths, and whenever they come to the hospital, right? So they need to be properly guided to provide PEP. And in this light, awareness is very, very important, because we need all of them, all those animal bite victims, people who have been bitten, should reach the hospital, should at least contact the health workforce, including the ASHA workers at the village level. So that's the kind of awareness we have to bring in among the people. So starting from ASHA workers, and then they are referred to the sub-centers or the PHCs. So subsequently, doctors to provide a PEP. But when they arrive at the hospitals, so they need to get a proper post-exposure prophylaxis. In that light, this categorization of wound is very, 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 very important, because what we see according to our studies is majority 80 to 85% are all category 3. Where we have to provide the rabies immunoglobulin or the monoclonal antibodies. But from the other studies where we read and listen in some conferences from the different hospitals, we see the majority of bites are category 2, which is absolutely wrong. It is not correct. So all those people who have category 2 do not have received the immunoglobulin. In fact, they are all category 3. So this is where the training of the health workforce is very, very, very important in categorization of wounds. So once we have made aware of categorization, then other things are easy. Then wound wash, vaccine, immunoglobulin, administration, and also training the health workforce by training them in cost-effective intradermal rabies vaccination. That's very, very important, because now the government is thinking of giving pre-exposure vaccination, and maybe it is only by intradermal. If for the entire country, if it is being implemented, it will by intradermal. So we need to train our health workforce for providing the vaccine by intradermal route. And another important one is the life-saving immunoglobulin or the monoclonal antibodies have to be properly infiltrated into the wounds. That is very, very important. Not giving systemically, which is of no use. So these are the important things that we have to train. And other important aspect is strengthening the surveillance, means data collection and reporting of the animal bite case and rabies cases. So that's also important. It is being talked about in IDSP, Integrated Disease Surveillance Program, and also notification of diseases, another important thing that has come up. And the last is very important. One is establishing and strengthening the laboratories at the national level or regional or the state level. So the involvement of medical college personnel is very, very important, because we have more than 750 medical colleges in the entire country. Yes, we want to achieve zero eliminating documented human rabies by 2030.
Thank you so much, Dr. Ashwath. Very rightly pointed out, sir, all the points that you discussed do need due attention and work The next question is to Dr. Sumit Poddar. Sir, as we are seeing that there is persistent gaps in the existing vaccines that are there, but there are also newer products such as emerging biologics in this regard, which are not only cheap but also available, readily in different parts of the country. So, I wanted to know if there are any challenges observed around biologics as well in your experience, and in the community. Are there any challenges in terms of product acceptance, product technique, or availability in remote areas, or are these readily available that can be adopted as a good alternative? So can you please unmute yourself? Yes,
Am
sir.
I
Please go
audible?
on.
Can
Yes,
you hear
sir.
me?
Please go on.
Can you hear me?
Yes,
Hello?
sir. We can hear you.
Oh,
Yes.
one thing that to control rabies is very difficult, number one, but we'll have to try. The main measure that we'll have to take the school level education. They do not have, it is not being included in the syllabus, so that if it is included in the syllabus, then the people's most victims are the children. So it is needed to place the hoardings and also take the classes. In our last conference, year before that, in Calcutta conference, already we invited the small childrens to at least to make aware that what is rabies and how it is being transmitted, everything has been like this. We will have to do these programs throughout the country, number one. Second, training of the doctors. That is very important because most of the doctors, actually, they'll have to take the special training on the animal bite management. So it is very important. Actually, if I miss one point, then we can lose the patient. So as the life is very valuable, we'll have to move accordingly. Third, placement of hoardings, I told it. Fourth important part is the vaccination, implementation of the pre-exposure prophylaxis to all. So that why this is needed? Because in case of the patient receive the pre-exposure prophylaxis, in case of post-exposure period, he will receive only 2 doses of vaccine. That is a cost-effective 2 doses of vaccine, and rabies immunoglobulins or biologicals is not being, the rabies immunoglobulins are not being needed. So it is the main thing. And the fifth thing is we'll have to follow the guideline of WHO and also the guideline from the NCDC as it is being, we are following still now. And also the guidelines, special guidelines are also, we are from on behalf of APCRI, we are also repeatedly doing certain programs. So these are the most important things. First of all, the people should know, the doctor should know, the main treatment is wound wash for 15 minutes, so that the first part, as the first part. Second is if it is category 3 or any bleeding would come under category 3, we will have to give the rabies immunoglobulin to neutralize the virus at the site of entry. That is the second thing. And third is the vaccine. The vaccine can be given in the Asian schedule or in the TRC schedule, that is tri-retro schedule. So it is very important to do the complete treatment, and the patient should know once the treatment he has received the primary treatment here with the vaccination or all these things, in case of further exposure, he will not require rabies immunoglobulin, and only 2 doses of intramuscular or intradermal doses of vaccine is sufficient enough to raise the antibody level and keep it as such very safe for the patient. So it is very important. And other important thing is the help of the other sponsoring. The main is from the NGOs and also the pharmaceutical companies. They are having a great role to play, because we'll have to think for a shorter course of vaccine. So the time has come when we'll prepare the low dose vaccine or 2-dose, 3-dose vaccine that is enough, that the patient will get the 3-dose vaccine within a very short time, and he will be protected. So these are the newer research, newer molecules should come, biologicals, and the cost of the treatment is also very less. Still now, the outside treatment cost is high, but in government level, the treatment is free throughout India. So it is the main thing, and I strongly believe that the rabies, in case of rabies, at least research work will come. Many diagnostic laboratories should set in, and also with the estimation of antibody response, it has to be calculated properly in a diagnostic setup, and so that we can do much better result in this continuity of the treatment course.
Thank you so much, Dr. Poddar. Very quickly, I will take 3 more questions before we wrap up this session. One is from Dr. Sudarshan. Sir, echoing the same question to you as well. Do you see any, benefits of having newer products that are required? As Sir said, we need more low dose or shorter course, vaccines that are required. So, do you feel that, what kind of challenges do you feel that are there in the existing products, and what kind of, if there is a necessity from what you have observed as well for shorter course vaccines and other newer products that are required? Over to you.
Yeah, thank you. Whatever is available, if it is put to the best use and the correct use and an updated use, that is good enough. Like, for example, we have got now rabies monoclonal antibodies. They need to be now widely used, more so in places of rabies immunoglobulins, which are developed from either human or from animals. So as per the WHO recommendation, rabies monoclonal antibodies are the new armamentarium to prevent rabies. Now, next is reducing the number of doses. Now, globally and by and large in many countries, the intramuscular dose has been reduced from 5 to 4 doses, and intradermal regimen is reduced from 4 to 3 doses. So, if this can be examined in the country through some clinical trials, I think we will be able to do a good progress and achieve greater coverage and also reduce human rabies deaths. I think this is what is currently needed as of today, as of now. For paucity of time, I stop here. Back to you, Dr. Sawant.
Thank you so much. As we have industry experts also here with us, let us hear from them. Mr. Srivastav, sir, as the doctors have been echoing the same, that, newer products are required, which take up less number of doses. So are there any efforts that are being made in this regard? If so, what we would like to know, if you could share us. Also, if you could share us any newer technologies or products that you are working towards with your organization that may come up in future, we would like to know a little about that as well.
See, at this point, Dr. Sudarshan said the methods which are available or the product which is available is good enough. I think that answers all, because rabies is one thing, it's 100% lethal. So it does not give you a scope to try and invent several things, and it has been talked pretty often. Once it comes to rabies, like if you talk about the medicine side, it is never recommended that you over treat a patient. But once it comes to rabies, Dr. Sudarshan pretty often says that it's fine to over treat if you are in doubt than under treat, because under treat can take a life. So instead of inventing shorter duration, longer duration, unless it is well tried and tested, once we have the clinical data around it, that yes, reduction of doses can be helpful in a larger population, It has been tried, tested, proven. Yes, we should do that. But till we do not have that, it is better to stick to the time-tested methods, because it should not happen, somebody becomes victim of our test and trial, because then we cannot bring the patient back. At the moment, what we are trying, and it's very heartening that various companies here, for this purpose, they do not compete with each other. Rather, we join hands with each other in spreading awareness by various names that suits us. Okay, so at this moment, instead of venturing into the inventing into the newer regimen for that, I would say let's join hands in spreading awareness. And all, please tell people, tell children, tell parents, open that channel. And whenever there is some doubt, even the scratch, don't judge yourself. It's a minor scratch, you will be fine by evening. No, please take him or her or child to the doctor and let doctor decide what's good. And as Dr. Aswath Narayana was mentioning, that awareness at the doctor level of they can do the clear categorization and give either anti-rabies vaccine or the immunoglobulin, or both, or as required. Let doctor decide that. So we should not be judging that, right? So the current regimen that we have are the time tested. They are known to protect lives. We have trust over several decades, and I think we should stick with that. And yes, there are some new innovations will come, but we should give them good time for a good trial and test in larger population and have documented results. Then only we should opt for that. That's my
Of
view
course.
on that decision. Thank you.
Of course, very well said, and definitely due diligence in this regard in research and seeing the how the effects are for few years are very much necessary. At the same time, as echoed by all the panelists today, awareness regarding this amongst the medical community as well as general public is very much required still, and specifically focusing on the younger population as they are bitten the most. My last question of the session is to Mr. Nitin. Sir, can you please talk about how the latest advancements in the technologies are helping bridge this gap that is there for India to reach their efforts towards zero deaths by rabies by 2030, and how can these latest technology products be adopted to help amplify our efforts towards reaching this goal?
Thank you. I think we have discussed a lot of it in bits and parts, so I will be respecting the time and keeping it very short. I think it's important that we continue to focus on strengthening the collaborative approaches. NRCP and CDC have made a lot of strides. All the stalwarts who are part of this panel discussions in individual capacities and as an organization or society have been working together. It's important that we continue to scale up the bite categorization awareness. That would only help, for the right treatment. Availability of vaccine is not going to be a challenge. We need to be sure that the clinically proven dose strategies are adopted, and that's where vaccine availability is not challenged. And so is the case with the innovative products like cocktail of new monoclonal antibodies which are available in the market, which are developed in collaboration with WHO. There again, those can be produced in the large quantities. It is going to be important that this kind of treatment options are adopted across this healthcare practitioner spectrum, so that the challenges which were available earlier when with regards to the immunoglobulin in terms of the sensitivity test or the adverse reactions or any kind of safety issues are not there with the current treatment options like cocktail of monoclonal antibodies. And hence, it's going to be important that for rabies-free India, we all put together a very aggressive and collaborative effort, which would basically mean that we adopt the newer technology in digital, we go for the strong communication to the communities, and we bring in capabilities in the healthcare practitioners, which is going to be the need of our. So I would say that tackling the gap of rabies immunization in India, it requires the multifaceted approach, collaboration among stakeholders, innovative solutions, and a collective commitment to achieve zero death by 2030, and probably much before that in India.
Thank you so much. With that, we would like to wrap up this session of the conclave. I would like to thank all the eminent panelists for taking out time from the busy schedule for imparting us wealth of knowledge and information on this World Rabies Day on rabies awareness. Thank you so much, Dr. M.K. Sudarshan, Dr. Omesh Bhati, Dr. Sumit Poddar, Dr. D.H. Ashwath Narayan, Mr. Shakur Srivastav, Mr. Nishtin Jain. Thank you so much. I would also like to thank our partner, VIRAM and Zydus, for taking this brilliant initiative forward for raising awareness around rabies on this World Rabies Day. Thank you so much. With that, we move on to the next session, which is on the topic of an integrated approach to rabies prevention, current status and action. I would request the audience to please stay tuned and let us go on to that. Thank you.
Thank you, Dr. Sawant and Dr. IHW.
Thank you.
Thank you so much, Dr. Sawant. And
hello and welcome you all to the 4th edition of Integrated Health and Wellbeing Council's Rabies Awareness Summit. This is a joint initiative of IHW Council and VIRAM, full stop on rabies, and it's being powered by Zydus. Today's topic for this episode and discussion is an integrated approach to rabies prevention, current status and action. Today, we will be discussing on different aspects around rabies prevention. According to World Health Organization, rabies is a vaccine preventable viral disease occurring in more than 150 countries and territories, but India is endemic for rabies and accounts for 36% of the world's rabies deaths. Dogs are the source of vast majority of rabies deaths, 98 to 99% of rabies deaths as reported, and of all the rabies transmissions that occur to humans. The true burden of rabies in India is not yet fully known, although as per available information, it causes 18,000 to 20,000 deaths every year. About 30 to 60% of reported rabies cases and deaths in India occur in children under the age of 15 years, as bites that occur in children often go unnoticed and unreported. Rabies deaths in humans are 100% preventable through prompt and appropriate medical care. That is why we have all gathered here today on World Rabies Awareness Day for discussing on this integral topic on an integrated approach to rabies prevention, current status and action. Please allow me to introduce our eminent speakers present here for this discussion. This panel is a mix of expert decision makers, opinion leaders, administrators, head of department, and have all been instrumental in providing consultancy in different capacity to strengthen India's mission of zero death by 2030. I welcome Dr. Jugal Kishore, Director, Professor and Head of Department of Community Medicine, VMMC and Safdarjung Hospital, Ministry of Health and Family Welfare, and has more than 320 research papers published in national and international journals, as well as authored more than 40 books on public health, national programs, social reforms, and rationality. Sir, we welcome you to the show. Thank you for joining. We welcome Dr. Akhil Dinesh Goyal, who is Additional Professor for Community Medicine and Family Medicine, AIIMS, Jodhpur, and is also the Nodal Officer for Yellow Fever and Adult Vaccination at AIIMS, Jodhpur. Sir, thank you so much for joining. Welcome to the show. We welcome Dr. Rajneesh Kumar, who is the Chief Medical Officer and in charge of MVID Hospital, New Delhi, and ex-Medical Superintendent of BR Hospital, New Delhi, and past Zonal Representative of North Zone for the Association of Prevention and Control of Rabies in India, APCRI. Sir, thank you so much for joining. I welcome Dr. Ravish H.S., who is Professor of Community Medicine at KIMS, Bangalore, and is also the Secretary General for Association of Prevention and Control for Rabies in India. Thank you so much for joining, sir. I also welcome Dr. Anurag Agrawal, who is Professor of Department of Pediatrics for Maulana Azad Medical College and Associated Lok Nayak Hospital, GB Pant Hospital, and is the Executive Board Member of CIAP 2021. He's also the President for Indian Academy of Pediatrics, New Delhi, 2023, and founder of Secretary Consortium Against Rabies. So thank you so much for joining. With that, let us move on to discussing on this very pertinent topic of rabies prevention and current status and action in India. So, according to some recent studies, one published in November 2022 in the Lancet Journal of Southeast Asia, it highlighted that in India, a sudden spike of number of cases of rabies has been observed. Deaths due to rabies amongst vaccinated and unvaccinated individuals, both, especially in some states such as Kerala, have caused a greater public health concern. There has been many incidences of specific reports that this report highlighted, and there are also news of more than 9,000 animal bites that came from Noida. Recently, a 14-year-old rabies victim from Ghaziabad also was highlighted. So my question is to Dr. Jugal Kishore, sir, what are your thoughts and views on the current status of rabies prevalence in India? If you could share your views on the same.
It's very, actually, when we talk about the, prevalence is of two types, point prevalence and period prevalence. The point prevalence is quite difficult because, once the disease occur, then within few days or maybe within two weeks, the person die. And it is difficult to capture it. So any point of time, if you try to get the number of cases of rabies, then you'll not find. But in 1 year, how many have died? Rightly said that world over it is 59,000 deaths are occurring, and majority of the deaths are, in Asia, and India contributes almost, around 18 to 19 or 20,000 deaths, which is a big number because this contribution to the world in average is quite big. But actually, the death in India is, you will say the death is quite common because of many others. So 20,000 does not appear to be very big one. But when we calculate it in terms of the, losses, the daily loss, then it comes to be very huge. So overall is 3.7 million daily are lost. And when we convert it into how much money is gone because of this rabies, then it come out to be $8.6 billion US dollar. So a huge amount of the economic loss occur because the majority of the people dying which are young, as you rightly said that less than 15 years people died, so they have whole life which should have been taken care of when we are calculating such kind of burden. So the better is to find out how many numbers, and unfortunately we do not have very good data or surveillance based number. uh, Although you have said, in some state it has increased, the comprehensive data is not available, but whatever data is there, the recent surge could be because of the, I personally feel as a epidemiologist also, the number of, the disaster occur or say flood occur, then the animals, particularly dogs, become furious, and then the bite can be a little higher. So that is what. But in nutshell, you can say, one deaths occur every 15 minutes. Then people realize, yes, it's a big one, and majority are younger population, and you know, uh, and you can say the majority actually because of the dog. So we can focus on dog. Almost 97 to 99% are because of the dog bite, and which is now people are becoming dog lovers, and then cat lovers. So there is an interaction, and which is increasing in number. Uh, Therefore, the bite will also be high. In one calculation, I found that around 117 crore according to government expenditure, and almost double of it private expenditure on the post lakhs dog bites occur, and we have to manage. So not every dog bite is managed properly, leading to lot. If we can vaccinate the dogs, 70% of the dogs are vaccinated, then rabies transmission can be stopped. And we have the vaccine for human being and animal both. What is required is the best available vaccine given to everybody, even before exposure to bite, like the pre-exposure prophylaxis, which is the best one, but it's a huge number of people are there. So one has to find out which group can be vaccinated fast, and whoever is left, is post-exposure. And we found that in post-exposure, the number of doses are less required when person is already received the pre-exposure prophylaxis. So that is overall, the status which can be managed when we talk about, prevalence of the disease. Ashwari.
Thank you so much for sharing those, sir. And very rightly pointed out, one rabies deaths in 15 minutes. That's the same as highlighted by World Health Organization as well when I was going through some of the studies. On the same note, as this initiative of rabies prevention has been carried forward since many years in India to reach our target. Our next question is from Dr. Rajneesh. Sir, if you can, please highlight, share some key initiatives that are being done by the government, by NRCP, by NCDC for rabies prevention and control in India, and also so that our viewers can understand more on that.
Thank you. Government of India launched a National Rabies Control Program in year 2012 in 8-5-year plan. But initially there was some funding issue, very little amount was allotted to that. Before this launching of NRCP program, Government of India has also taken some pilot project in 5 cities. One of city was the Delhi, or Delhi was the nodal agency, is the Municipal Corporation Delhi. Or our hospital was the part of that, the pilot project. That was the successful project as per our experience in the MBID, infectious disease hospital, which is the only hospital in the whole northern region. So we used to get about more than 200 cases per year before this pilot project. After this project, cases were drastically reduced up to the about 50-59 cases. Again, there was some interval between the pilot project and the full-fledged launching of the NRCP program, and this again cases rising again, or this go up to the 116 point cases per year. Again, at present we are receiving only, last year we have received only 55 cases. Again, this year received only about 48 cases till date. So this government of India which launched this in, or recently as per the international organization mandate, we have to eliminate the dog mediated rabies by 2030. Government of India launched a national action program for prevention of dog mediated rabies that comes in implementation in year 2021. It has 2 components. One is the human component, other is the animal component. Human component is entails that the ability of the post-exposure prophylaxis to all, and other is the capacity building, training of the manpower, whether it is doctors or the paramedicals. All we have to train to full capacity building. Third is the surveillance purpose. So strengthening of surveillance system, we have developed, we are now started reporting through the IDSP, this, whether it is the rabies case or whether it is the animal white case, both are reporting through these systems. So surveillance system is also strengthened. Third point about is the appropriate communication strategy. So we have also developed a strategy and public-private partnership. So there are different NGO and other which are involved in this human component also, just like APCRI, so many things. Other things is the veterinary component. Veterinary component, first thing is the estimation of the dog population. How much dog you having? Second thing है कि mapping risk zone for the rabies diseases. And third is the progress of the mass dog vaccination and effective management of the disposal of the solid waste so that dog population can be minimized. And third is the operation research. And fourth, promotion of responsible dog ownership. So in Delhi, Municipal Corporation of Delhi has also mandated the registration of dog, which is actively now. It was, although it was an act, DMC Act, it was already in, but department is not giving the more focus on that. But now they are taking in as an initiative to all the pet dogs should be registered as a voluntarily. And they are also taking action for the penalizing those who are not registering. So government is doing it. Other things regarding the availability of the biologicals. Recently, Ministry of Health, Family Welfare directed all the states, you can use the NHM fund for the procurement of these biologicals as essential drugs. So previously, we are using this fund from the other fund. In Delhi, there is a no scarcity of the biological, whether it is the anti-rabies serums or anti-rabies vaccines. There are three types of anti-rabies center in Delhi. One is the central government, just like the Safdarjung Hospital, RML, and others. Second is the SNJP, Delhi government hospital. A third is the our setup, that is the municipal corporate hospital. So we are not dependent on the NHM fund. We are also procuring these biologicals from the own funds. So there is a no scarcity of the whether it is a Delhi government or municipal corporation hospital or the government hospital. So as per as ability of concern, there is no ability issue in the Delhi. One thing is very what I have seen in the infectious disease hospitals, we have received many cases where proper post-exposure vaccination was not given. Even patient had attended some tertiary care hospital, probably due to unawareness of the health manpower and due to lack of sensitization of the healthcare manpowers. So if we wish to achieve the rabies prevention by zero death by the up to 2030, so we have to ensure two things. One thing is the key, every public should be aware about the what is the post-bite treatment, which consists of proper wound management, proper and timely wound management. Second thing, and second thing है administration of anti-rabies vaccine, and if it is a serious case, that is category 3, administration of the anti-rabies serums. Second approach is regarding the every medical fraternity, whether it is a doctors or the paramedics, they have to ensure that all the person, those who are bitten by any animal, should get appropriate post-exposure prophylaxis. This can only be happen with the proper sensitization of the medical personnel and paramedics.
Thank you so much, sir, for sharing all the different things that you highlighted. Also wanted to know one thing, that you shared that primarily in 3 types of centers the anti-rabies vaccine is available. Sir, where do the private hospitals come into play? Is anti-rabies vaccine available in private centers as well? Or is it just available in the ones that you have?
Okay. In Delhi, there is some centers which provide anti-rabies post-PEP in round the clock, just like Safdarjung Hospital, RML hospitals, where serum immunoglobulin is provided round the clock. Basically, it is administered in the casualty. Or as per my opinion, if we treat as a animal-wide case as a case of emergency, or it is provided in the casualty itself, so it can serve our purpose very well. So other type of hospital which provide a PEP during 9 to 4, and third types of the healthcare center which provide only 9 to 2 only, or they are only just like the dispensary and polyclinic, they are only providing the anti-rabies vaccine, not the serum. So serum is only administered in the tertiary care center in the hospitals, as per the MCD and Delhi government is concerned. So they are not provided in the lower level. So the patient has to travel the tertiary care hospitals. So as per our case study, I have also analyzed the last 5-year cases. So in Delhi, our proportion of cases, we have already get 55 cases last year. So Delhi proportion is only very reduced. Only Delhi, only 20% cases. Previously, we used to get to 40% of the Delhi cases. So the rest 80% cases are there from the adjoining state, not from the Delhi. So Delhi has achieved a remarkable achievement in reducing the disease in the rabies disease.
Just to add, I think Sir has explained very well. Your question regarding the private one, all the private hospital and even general practitioners are giving the vaccine whenever or anybody wish to get it. They are available in the private shops or maybe pharmaceuticals. So the pharmacy all have the vaccine. So anybody here in a government hospital where the Sir has explained, it is free of cost. And what is important now in national action plan is that we have shifted from, just human to now animal, and both the component are there. And the best part is the One Health approach has been now advocated, where we have involved the veterinary sector and other, sectors coming together, not only just, the animal husbandry, but also agriculture, IT, DSC, science division, all are coming together to make the program successful. So, and that also advocate that not only the national level we have the plan, but state level they have to make the plan, and district level they have to make a plan. Although it will take time, but the government is pro to develop such kind of plan so the things can be more in line with what the zero transmission is possible in 2030.
Thank you so much, sir, for highlighting that. My next question is to Dr. Ravish to know, sir, where we are realistically on our path to achieving the objective of zero deaths from rabies by 2030. Please, sir.
Definitely, we can achieve the zero by 2030 as per the guidelines from WHO and by the initiatives of the Government of India. As Sir has already told you regarding the NAPRI, that is National Action Plan for Rabies Elimination, and in turn SAPRI is on in almost all the states. Definitely we can achieve. Only thing is there are so many things we have to look into it, and we have to see how it can be worked best, starting from the categorization of bites. And of course, before to that, whenever there are animal exposures, the health seeking behavior of the patient is important. So we have to focus more on the health education part of the community per se, whole of the community itself. That is of utmost importance. Once they come to know, they have to seek the proper treatment or post exposure prophylaxis. Naturally, they will come to the hospital. In the hospital, of course, it's most important the doctor has to know correctly what they are supposed to do. The first thing is in post exposure prophylaxis is to categorize the wound properly, whether it is category 1, 2, or 3, because the treatment depends upon the categorization of bites. So that is the second most important thing where there is a scope for improvement. The third thing is regarding wound wash, and many of them doesn't do it. So once again, it has to be told to both the community personnel as well as for the doctors the importance of wound wash, which can remove most of the virus at the site of deposition itself, where the saliva is there. So that is also very, very important. And the third more important thing is regarding anti-rabies vaccination. Here, of course, all of us know for any animal exposures, whether it is category 2 or category 3, a full course of anti-rabies vaccination is a must, whether it is intramuscularly on day 0, 3, 7, 14, and 28, or ID, 2 sites of 0.1 ml on day 0, 3, 7, and day 28. So the course is roughly about a month. So the compliance is a big question. So once the patient comes to the hospital, we have to start the vaccine, and we have to counsel them so that they are supposed to come for the complete dose of vaccination. Otherwise, the protection levels will not be there. That has to be told to them so that they can listen and properly come. And we should have a tracking mechanism. And everybody now has got a mobile phone. We can track each and every patient so that we can give a call and let them come on the dates which they are supposed to take the vaccines. And of course, the availability of vaccine and all those things we'll discuss on the later things, how we can move about. And finally, the rig administration or the RMAB administration. Of course, all of us know that in all category 3 exposures, whenever there is a bite or a scratch with any small amount of bleeding, is considered as category 3 exposures. In those circumstances, they are supposed to take local infiltration into the wound with rabies immunoglobulins or rabies monoclonal antibodies, which are the latest ones to be added for passive immunization. So these are the things they should focus. And the government, of course, has taken the first step with regards to NAPRI and SAPRI. But implementation at the state level differs in each state because health is a state subject. I think all of us know it. Implementing at the state level is not an easy task. So it's always preferable. It's like what we are providing at the National Immunization Program. The government from the center itself, it is always better to supply both the rabies biologicals for post-exposure prophylaxis, whether it is anti-rabies vaccine or rabies immunoglobulin or monoclonal antibodies.
Thank you so much, Dr. Ravish, for giving us the step-by-step as to what to do after, you've been bitten. So my next question is to Dr. Anurag. Sir, we would like to know if there are any challenges in specifically the categorization of the bite, and what would be the most crucial, steps when we are to manage animal bites for both the sets of audience that we are catering to, lay people who would want simple steps to reach out to solve this animal bite issue, and also from the practicing clinician's perspective as to what to do and what would be the right sequence of steps. So Dr. Anurag, yes, over to you.
Yeah, thank you for having me on the panel. So first of all, what are the challenges? The first challenge is categorization. We have been facing this problem right from the layman to a healthcare worker. In fact, daily I get calls, sir, this is category 2 bite. And it is so difficult to explain to a layman and a healthcare worker that any bite wherein there is even a drop of blood or serum oozing out from the wound, it is category 3 bite. So a simple way of assessing is that there is a breach in the integrity of the skin and there is a drop of blood or serum coming out, or there is a scab formed on that side. It is category 3, extremely simple. And if you are in doubt, take a spirit swab and move it onto the wound. If there is burning or tingling, that means it is category 3. It is that simple. And this message needs to be communicated to the lowest level of health worker and to every lay person, whoever is exposed to or can be exposed to an animal bite. Now, if you look at the incidence of animal bite data, multiple data sets have been collected. Various studies have been conducted across the country. For example, we conducted a study in 2015 or something, 14 in fact, and an earlier study was conducted in 2004 and various other studies. They are showing the annual incidence of dog bite as 2.5%. So out of 100, 2.5 patients every year, 2.5 general population every year will be exposed to a dog bite. This simply means that over next 40, 50 years, everybody will definitely have a dog bite, at least in this country. Looking at the amount of strays roaming around on the streets and the way these dogs are being fed and the amount of aggressiveness these animals are developing nowadays, there is a huge possibility that we will all be exposed to dog bite. Now, the question is that what can we do about it? So we want to be rabies free by 2030, right? So there are multi-pronged approaches which we can have. The first is animal vaccination, and the second is vaccination of humans, that is pre-exposure prophylaxis. So if you take a vaccine beforehand, before being exposed to a dog bite, that is 3 doses, 0, 7 and 21, that is the present schedule. Later on it is going to be modified, but presently we are following this schedule. You have an immunity lifelong, and in case of exposure later on in life, you just require 2 doses of the vaccine and no immunoglobulin. So this is one of the approaches which NAPRE is trying to implement through Government of India. And we at association levels, that is Indian Academy of Pediatrics, an association of 42,000 pediatricians across the country, we recommend that all the children should take pre-exposure prophylaxis. So what IAP, Indian Academy of Pediatrics, is doing is, it is spreading awareness amongst all its pediatricians to give pre-exposure prophylaxis. And in case of exposure to animal bite, if you have not received pre-exposure prophylaxis, correct categorization of the wound, that is any wound which has a drop of blood or serum or tingling or burning, on application of a spirit swab, you have to give rabies immunoglobulin into the wound. And of course, followed by vaccinations. First of all, wound washing, then immunoglobulin, and then completing the course of vaccination. So this is the kind of awareness we want to spread across the country through to all clinicians, to all healthcare workers, to the ANMs, to the Anganwadis, and to laymen, that every dog bite has to be taken carefully, treated according to guidelines, so that we are able to have 0 rabies deaths by 2030. Thank you.
Thank you so much, sir, for highlighting that. My next question along the same lines is to Dr. Akhil. Sir, as Dr. Anurag highlighted that, if there is any sort of break in the integrity of the skin, if there is blood or if there is any oozing of serum, it is considered as category 3. So in your practice, how many percentage of patients that you see are category 3 that come to your setting? And again, how many of them come to you that are clearly category 2 or 1 without any oozing of serum or blood? So in real scenarios, what is the case?
Thank you. Thank you for having me on this panel. And thank you for that question. So Dr. Asabri, actually the patient who reaches the hospital are usually those patients who are mostly category 3. We see very rare category 2 or category 1 patients. And in fact, when there is an aggressive dog who is attacking someone, it is unlikely that there is going to be only a superficial scratch or a breach in the continuity of skin without oozing of blood. So most of the times when we are looking at a patient, it is category 3 wound only. Sometimes, rarely we do get category 2 or category 1. In respect to the categorization, the first and one of the most important steps, which is not very costly also, is to wash the wound properly. And the guidelines say that we need to wash it under running water. There should be flowing water for a period of at least 15 minutes. With soap, simple soap that is available with everybody. With simple soap, if you're able to wash the wound, the chances of having a rabies later on reduces to a great extent. However, majority of the places at homes, even at hospital, the facility of washing the wound and the patients of washing it for a period of 15 minutes under running water is not usually done. Second step, once we have washed the wound, be it category 1, 2, or 3, the second step is to decide whether vaccine needs to be given or not. Both for category 2 and category 3, the vaccine needs to be given. The pre-exposure, or in this case, after a potential dog bite, a post-exposure vaccination needs to be given only when you are completely sure that there is no breach in the continuity of skin. There is only sort of a lick on an intact skin. May you defer giving the vaccine. Otherwise, currently the vaccines which are available are very, very safe. They do not have any side effects. So in case of any doubt between categorization wound, it is always safe to give a post-exposure prophylaxis with the anti-rabies vaccine. And if there is oozing of blood, the immediate step that needs to be done within 7 days, that is the maximum limit, but it is advisable to be done as soon as possible to give the immunoglobulin or the monoclonal antibody that is available these days.
Thank you so much, Dr. Akhil. I would like to ask the same question to our other doctors present in the panel as well, who are seeing rabies cases. So what are the scenarios of category 3 bites? What is the percentage that you see commonly? Is it just like what Dr. Akhil suggested, 80 to 90% of patients that come are of category 3, or is it different from the location that you are practicing? Starting from Dr. Anurag, sir.
Yeah. So I think what Dr. Nikhil has emphasized is very right. Any patient who turns up to our clinic is usually category 3. But the important point, as I highlighted earlier also, is that the staff sitting there or the doctors sitting there should know what is category 3. What the doctor or the staff sitting there does is that he sees a small scratch and he says it is category 3, just category 2, just take the vaccine and go home. So again, this point is very important, that even a drop of blood, that means your integrity of skin is broken and the virus can penetrate through, it is category 3. Once this message is conveyed, maybe we will have lesser rabies deaths as compared to what is happening at this point of time. Thank you.
Thank you so much, Dr. Anurag. And sir rightly mentioned that, as we were reading some studies, and those studies were referring that 40 to 60% of cases only come under category 3. So would it be justified to say?
Yeah,
Yes.
let me explain,
Yes.
Ashwari. Actually, when it comes to the tertiary care hospital, then the category would be high. When it comes to a primary care center, or maybe even primary care also, when somebody is approaching to a doctor, definitely when he or she feels that something is wrong. But nowadays, because the people are having dogs and cats in their house, and on the street, there are so many, and they are touching them, leaking, and are very common. So in that case, it is very difficult to say that, say, category, which kind of category, because usually the category 1 is not to be considered as category 1, because you nothing to do, only just to wash. And every time when your dog is licking you, you have to keep washing your face and hand and all that. That is why maybe the category 1 is defined that whenever there is a contact, you should wash. But unfortunately, it is not happening. Majority of the contact is actually category 1, but category 3 is coming in a small proportion. But the people who are coming to health center will be majority, which are category 3. That is why the difference is. So where you are conducting the survey, or where you are trying to find out the problem, you can define these percentages.
Thank you so much, sir. Just to conclude it for our audience in easy sense, so as highlighted by our panelists, so if there is any blood or serum that is oozing, or any break in the integrity of the skin, that is if you are applying soap or any sort of liquid on it and it is burning, that means that it is category 3 already. And if it is category 2 or category 3, you need to go get the vaccine done. So, sir.
Be considered as category 1. But then the recommendation is also that the pet dogs should be vaccinated. So the risk of transmission from a pet dog is very low. But in case there is a lick from a roadside dog, from a stray dog, then the recommendation is that we should wash the wound. And in case there is no breach in the continuity or there is no pre-existing wound on which the lick has happened, then you need to only wash and the vaccine is not required.
Thank you so much, Dr. Akhil. So, moving on to the another section of the discussion, which is pre-exposure prophylaxis. So, my first question is to Dr. Anurag, sir. Can you please highlight that in order to get everybody to, obtain the post-exposure prophylaxis, I believe there is some sort of shortage in the availability of the vaccines as well, which is causing some sort of issues as I went through some of the articles. So please correct me if I am wrong, and also highlight that if we were to reach our target, that is 0 deaths by rabies, would post-exposure prophylaxis or vaccinating all of them in general would be a crucial element in reaching that goal, or how it is?
I think you meant pre-exposure prophylaxis. Pre-exposure means before you are exposed to a dog bite. Yes, if you want to immunize the whole country and do it in a campaign mode wherein you want to give the vaccine to each and every individual, starting with your pediatric population, it will lead to vaccine shortages. I agree with that. But the industry which we have is so robust in our country. All the vaccines are being manufactured locally in India. So you give the industry time of 1 or 2 years, it will produce sufficient vaccines to immunize the whole country. Look how we managed with COVID. People were saying with the rate we started, it will take 10 years to give COVID vaccine to the whole country. And we finished off in hardly 6 months. So here also, we have capacities, we have the industry there to support us. Other than that, there is a beautiful innovation which took place around 15 years ago, wherein we give the vaccine by intradermal route. So one vial which was being given to one patient can now be given theoretically to 10 patients, practically to around 8 to 9 patients if you use the ID route. So your cost comes down drastically and your vaccine consumption comes down drastically. So if we use this technique in our vaccination schedule, especially in the pediatric population, wherein we are giving other vaccines, we may be able to cover a large chunk of population. And if we are able to do it in campaign mode and give it to our school children in colleges and school, like we did with MR campaign, measles rubella campaign, we will be able to cover our adolescent population also. And thus we will be able to break the chain of rabies transmission across the country. And maybe we have one of the prongs from the multi-pronged strategy to reach our goal of 2030 with being rabies free. Of course, another important component is animal vaccination, which we should not forget, because that is the main, ultimately it is the animal which is the reservoir. So if you prevent rabies in animals, you will require less vaccines and less immunoglobulins in humans. So both the activities along with animal birth control will have to be done. All the three activities will go in hand to be able to achieve our goal of rabies-free India. Thank you.
Thank you so much, Dr. Anurag. Following the same to Dr. Ravish, sir, what do you feel? Do people currently get the pre-exposure prophylaxis done if they have not been bitten by animal at all, or after getting bitten once, do they complete the course? And how is it, in that you experience in your practice?
Presently, most of them who are coming to our hospital in our practice is post-exposure only, after the bite, that is. Most of them. Pre-exposure is very rare. And mostly our hospital is in the city of Bangalore. So most of the owners of the pets will come who are educated or literate. So these people only they are taking the pre-exposure vaccination. And of course, some of the pediatricians also recommend here regarding pre-exposure prophylaxis. But it's always better to give pre-exposure prophylaxis, especially children who are in playful nature. You know that they will play in the fields, they will go to school, they will play in the parks where there are a lot of dogs, anywhere in the country. So it's always better, and they don't know how to protect themselves also. So these dogs attacks mainly the children. So ideally, they are supposed to be given the complete pre-exposure prophylaxis of 3 doses on day 0, day 7, and either on day 21 or 28. So that is which is recommended. But as on now, post-exposure prophylaxis is more when compared to pre-exposure. It is very minimal. But on a long term, pre-exposure prophylaxis is a must to eliminate the disease from the country. Thank you.
Thank you so much, Dr. Rabies. Dr. Rajneesh, sir, what are your views on pre-exposure and post-exposure prophylaxis? Would you recommend people getting, one or two both, depending on if they, feel if they are in this sort of zone which is more prone to stray dogs, or if they have a pet dog themselves? What would be your recommendations to the audience?
For national guidelines, at present, we are advocating the pre-exposure prophylaxis only for the high-risk group. Either they are veterinarians or healthcare workers or wildlife personnel, those who are visiting the forest. So at present, we have developed a new things in our hospitals. We are giving the intradermal vaccine. Suppose one dose has been withdrawn from the last patient, one dose has been, so remaining 9 doses we are using as a pre-exposure prophylaxis. Whoever better, either the patients or attendants or someone else. So those who are remaining doses, we are providing as a pre-exposure prophylaxis. But as per guidelines, as per government, ideally it should be those who are high risk, especially where there are more cases coming from that area, we can provide. But as per the national guidelines, they only advocate for the high risk groups for prophylaxis.
Thank you so much, Dr. Rajneesh. My next question is to Dr. Akhil. Sir, can you please inform us on how many percentage of patients do get the complete post-exposure prophylaxis in your experience? That is vaccine as well as the other that is recommended. So what is the real scenario that is present that you see?
Yeah, so in my experience, counseling the patient about rabies and what can be the problems with rabies disease, and many times rabies might occur years after exposure. So counseling the patient properly does the trick. Once you have counseled and may I dare to say frightened the patient about the possibilities and consequences of rabies, then usually the compliance is pretty good. So usually in my practice, I see almost 90 to 95% compliance. There are a few patients who are non-compliant, the major reason being because of traveling reasons. They are traveling to other places. So later on, I come to know that they have taken the vaccine from somewhere else. But usually in the practice that I'm into, the compliance is pretty good. The same thing at a primary care center may not be that good because many times the severity of the problem is not counseled properly to the patients. So a big aspect of ensuring good compliance is at the initial phase, at the initial visit only, we need to inform the patient about the importance of taking the vaccine, taking the immunoglobulin or the monoclonal antibody, and to take it in a timely manner.
Thank you so much, sir, for highlighting that counseling also has to play a very vital role when we are to reduce the overall percentages around rabies in overall consensus. The same thing I would like to know from Dr. Anurag as well, sir. In your experience, how many people do complete the post-exposure PEP that you see, and those as Dr. Akhil highlighted, counseling is important. So if you were in a case where the facilities are not prioritizing so much on counseling, what would be the numbers like in your opinion?
Okay, now I'm in. So I'll take the question in another manner. Number one is compliance from the patient. Number two is compliance from the healthcare worker. So we have talked about patient compliance. There was a study conducted by a group. I think Dr. Ravish was a part of it, or Dr. Ravish's mentor, Dr. Sudarshan sir, was a part of it. They found around 60 or 65% compliance for the till the final dose. So 64-65% patients, only these number completed the complete post-exposure prophylaxis. But the bigger problem is the use of rabies immunoglobulin. And for rabies immunoglobulins, there were multiple issues, which was number one was categorization, which was wrong. Number two was availability. Number three was affordability. So now some states across the country have free rabies immunoglobulin available in their supplies. A state like Delhi has around 40 odd hospitals administering rabies immunoglobulin. If you compare that to our neighboring states like UP, wherein recently they are having some amount of immunoglobulin supply, and Haryana did not have it till last year. Now Haryana is having rabies immunoglobulin supply. Then coming to Rajasthan, it has had rabies immunoglobulin free supply in its centers for last 7-8 years. So availability of immunoglobulin is an issue. But what happened suddenly was when states started asking for rabies immunoglobulin from manufacturers, because it is made from horses serum, we call it equine rabies immunoglobulin, there was a severe supply crunch. And that supply crunch took around 2 years because they needed more horses to be immunized, then their blood was removed, from which serum was separated, from which this immunoglobulin was made. It takes time to hike up the production. It took around 2 years for production to be hiked up. Another variety which we have is human immunoglobulin, which is made from human blood. And its supply is very, very limited. Cost is very high. For a person like, for a person weighing 60 kgs, it will cost around 20,000 plus rupees for giving HRA. So it is highly unaffordable for an average, leave an average, a middle class Indian also. Now we have two beautiful products available in our country. These are Make in India products. These are specific antibodies, which are monoclonal antibodies, which are being produced by two manufacturers in the country. And they are site-specific to the virus, and they are just single antibody. So if you take equine or human immunoglobulin, they'll have a mixture of antibodies. There will be lots of varieties of antibodies, whereas these monoclonal antibodies known as biologics are specific to the rabies virus, and ample amount can be produced. Unlimited supply can be made artificially for these antibodies. So when we want to cover the whole country, as we said that only around 10 to 15% patients are getting the complete treatment. If we want this to be hiked up to 60-70%, we need a good supply of rabies immunoglobulin. That is very difficult. So to replace it, we have a better product, which is monoclonal antibodies. So these antibodies are available now in our country for last 5 years, and around 5 to 8 lakh doses have already been used across the country without any major side effects and without any rabies case being reported after the administration of these monoclonal antibodies. They are very safe. You do not require animals for its production. You do not require human serum for its production. It is basically a artificially multiple myeloma immortalized cells mass in which a gene is inserted, which produces this antibodies, and this antibody is collected, packaged into vials, and there is very good standardization. So each batch contains adequate amount of antibodies as per guidelines and can be injected into the wound and will provide you adequate protection, which is what we need. So this is the future. We'll have to move to monoclonal antibodies if we want to eliminate rabies in patients who have been exposed to dog bites. So pre-exposure prophylaxis using ID route. Post-exposure, if you have not received pre-exposure prophylaxis, take monoclonal antibodies along with the vaccine, and of course, animal immunization and animal birth control measures. So all these will go hand in hand, and only then maybe we'll be able to reach our target of 2030 rabies-free India. Thank you.
Thank you so much, Dr. Anurag. So as you pointed out that definitely there is a great, lack in the supply and availability of the existing, PEP methods that are there in India, owing to the various different challenges, whether it may be, poor availability or, it's from equine or from human origin. So those sort of availability issues, which the newer technologies and newer innovations such as monoclonal bodies or biologics do fulfill. So I would also want to know, which would be the last question of this session before we part away, how is the uptake of monoclonal antibodies in real situations? Is it being uptaken by practitioners readily, or are there some resistance to it? If so, why? So from Dr. Akhil first, sir, if you can shed a light on this thing.
Yeah, so they are very well received, especially because they cost lesser than the RIGs, and they have lesser side effects. We don't need to give a test dose before administering a monoclonal antibody. The only problem which is existing both with immunoglobulins and antibodies, monoclonal antibodies, is that we have to administer it locally. So when the wound size is very small and the dose is in few mLs, maybe administering locally is a challenge for someone who is not used to administering the monoclonal antibodies in a local wound. Otherwise, it is very well received.
Thank you so much, Dr. Akhil. Dr. Anurag, sir, your views on the same?
Yeah. So what has happened is, in government, we have equine immunoglobulin supply, but the private sector is totally into monoclonal antibodies. So across the country, I have conducted lots and lots of sessions on this issue. And I find that nearly all the practitioners are very comfortable with using monoclonal antibodies, and hardly anybody has reported any major side effect. And none of them have reported a case of rabies after being administered monoclonal antibody. So the confidence level is very high in the private sector, especially pediatricians, whom I am in regular touch with. And their consumption is pretty good. Nowadays, most of them are infiltrating wounds happily. In fact, I get 2 to 3 calls a day. Today, I got a call from Canada, wherein the child was exposed to a dog and they said what to do. I said, see, I do not know the Canadian guidelines. I can tell you what we do in India. So monoclonal antibodies are the future. Private sector is using it. Some government sectors like some army cantonments have procured it. 1 or 2 states have also procured it and now are happily using it. See, human monoclonal antibodies are very costly. They are unaffordable. Their supply is limited. It is imported from 2 countries and we have to pay for it in dollars. And monoclonal antibodies is a very cheap alternative, unlimited supply, made in India, easily available. Production can be hiked up as much as you want within a month or 2. So it is the only future option which we have available to us for long term. Thank you.
Thank you so much. With that, we come down to the end of our discussion today. Very insightful discussion. We could go on and on discussing on this, but as we have time constraints, let us bring down. So very quickly to summarize, categorization of the wound is very important. If there is any oozing of blood or serum or any break in the integrity of the skin, it is bound to be, it is most probably a category 3 bite, for which you need to go see your doctor, get the vaccine done, get the entire post-exposure prophylaxis complete for good health and avoiding risk of contracting rabies. At the same time, there are large amounts of innovations occurring in our country with new alternative options that will fulfill any gaps in the demand and supply for vaccines or antibodies that are there through monoclonal antibodies, which biologics are also called. So please look into those for your patients or for yourselves. These are made in India and available easily. At the same time, in the end, we would like to conclude that vaccination, not just for humans, but for animals, is also vital. And the government is well on its way for reaching the target of 0 deaths from rabies by 2023. You and me just need to be aware and support the cause the best that you can. With that, I would like to thank all our speakers for taking out time from the busy schedule, imparting us with wealth of knowledge and information for the 4th edition of Rabies Awareness Summit, and and joint initiative of IHW Council and VIRAM, full stop on rabies, powered by Zydus. Thank you so much. We would also like to thank our partner for partnering up on this brilliant awareness initiative on World Rabies Day today. Thank you so much. And lastly, I would like to thank all our audience for staying with us till the very end. Thank you so much. With that, we sign off now. Stay happy, stay healthy.